the leading cause of mortality in people with severe mental illness. It's not suicide, for example. It's actually cardiovascular disease, which shaves off 20 years of life. And then, as Sharmili was alluding to, it's not something that's simple, right? It doesn't happen because of a single factor. It's quite complicated.
Someone living with schizophrenia, bipolar disorder, or depression has a much higher risk of dying prematurely than their peers, and not just from the psychiatric symptoms themselves, but from the cardiometabolic consequences, the metabolic dysfunction and resulting cardiac disease. And this is really an unmet need over the past decades that has existed, but hasn't been addressed nearly as well as it should or could be. Well, today I'm joined by two experts who are doing something about this. They're publishing research and publishing guidelines and really promoting the need for us to understand, diagnose, and treat the metabolic consequences of psychiatric care. So I'm joined by Dr. Margaret Hahn, who's a clinician scientist in the schizophrenia division at the Center for Addiction and Mental Health and a professor in the Department of Psychiatry at the University of Toronto. She has published extensively on the glucose dysregulation that occurs with psychiatric care. And she has a lot of wonderful thoughts about how psychiatrists really need to take the lead for diagnosing and treating the metabolic consequences of psychiatric care. And I'm also joined by Dr. Sharmili Tharanajah, who is a physician and research associate at the Clinic for Psychiatry, Psychosomatics, and Psychotherapy at the University Hospital in Frankfurt. And she also has published extensively on this topic, having co-authored with Dr. Hahn an extensive review and approach for patients with both depression and obesity and metabolic dysfunction. So this is really a critical discussion for patients and for clinicians to better understand the metabolic consequences of psychiatric care and, more importantly, what we can do about it. So I hope you enjoy this interview with Dr. Margaret Hahn and Dr. Sharmili Tharanajah. All right. Well, Maggie and Sharmili, thank you so much for joining me today at Metabolic Mind.
Yes, it's great.
Thank you, Bret, for inviting us.
It's great to see you both. And especially now, I mean, you've both been very productive. You've had a number of publications, a lot centering on this concept of psychiatric treatment and the downside with the cardiometabolic risk that ensues for a lot of the treatments that we have as sort of our first line go-to treatment. So I want to get into the papers you've published and sort of the findings and what it means for clinical practice and future research. But first, give us a little bit of your background and what got you interested in researching this field or getting into this field in the beginning. So Maggie, let's start with you.
Yeah. So when I was doing my training in psychiatry as a resident, I was on the inpatient ward, actually the first episode psychosis ward, which, included very young individuals, late teens, early 20s. And people were being treated with our psychotropic medications, like antipsychotic drugs in particular. And I was seeing this immense weight gain, development of like early metabolic syndrome, in people who shouldn't have these types of side effects. And nobody was sort of doing anything. And the field of psychiatry at that time kind of didn't know what to do. So when I went on to do postdoctoral and PhD training, this was like a topic that was very kind of near and dear to my heart. And I'm glad that the field is, progressing at, I think, what is a rapid pace now as compared to how things were, a decade ago.
Yeah, I think we should get into more of that about how things have changed, but it is remarkable how, a decade ago it was sort of like, well, that's what happens with these medications and you just got to live with it and without really addressing it. And there are reasons for that, but we can get into all that, but that's great to hear. So thank you for that background. How about you, Sharmili? What got you involved in this field?
Yeah, so I'm a trained neurologist and psychiatrist. And I really started studying medicine because I was like fascinated by the complexity of the brain, by the complexity of behavior. And I did my MD thesis on schizophrenia patients. So we know from epidemiological data from our clinical practice that there is this high comorbidity between metabolic dysregulation, obesity, and psychiatric disorders for very many years, but there is hardly any mechanistic studies, and they are growing now, but we really lack mechanistic studies and also like clinically direct applications of this. So that really got me fascinated about this topic.
Yeah, that's great. So Maggie, tell us a little bit about sort of the the field as you've seen it? You've already talked about how it's progressed, but tell us about how the research has progressed, and especially the research that you've done, that you've learned, and how it's maybe changed sort of your thought about this.
Yeah, and just to add to the background, we know as well that the leading cause of mortality in people with severe mental illness, it's not suicide, for example. It's actually cardiovascular disease, which shaves off 20 years of life. And then, as Sharmili was alluding to, it's not something that's simple, right? It doesn't happen because of a single factor. It's quite complicated. So, we have lifestyle factors related to the illnesses, like access to healthy diets, reduced activity, high smoking rates. We have genetic factors. So I think, it's been established over the past decade, and we've known this for longer, that there's like a biological link, in particular between type 2 diabetes and severe mental illnesses. And then there's this reduced access to medical care that I think both of us will speak to, where there's this historical silo working between medical specialties and psychiatry. And then finally, adding fuel to the fire are the psychotropic treatments that we use, which with really few exceptions cause significant metabolic problems, including a further elevation of risk of insulin resistance and type 2 diabetes beyond like that intrinsic risk. And the worst offenders, or at least the best studied offenders of this risk, are antipsychotic medications. And what's interesting about antipsychotic medications is I think clinicians see this like pronounced weight gain, right? So some people will gain like double their body weight literally with these drugs. And for sure, we know that weight gain is a leading risk factor for insulin resistance that then can lead to type 2 diabetes. So, these drugs are life-saving medications, but they have a huge metabolic burden. So with my colleagues, what we decided to do, and this work was co-led by my very talented postdoc, Dr. Emily Smith, and my two very close collaborators, Dr. Mahavir Agrawal, who's in Toronto, and Zach Freiberg, who's in Pittsburgh. So we did a systematic review and meta-analysis, and we wanted to look at a very broad population. So we looked at all severe mental illnesses. We also included healthy controls, and our inclusion criteria were basically any study that was a blinded randomized control trial, or RCT, and it had to have a control group, so like antipsychotic or placebo. And that was kind of the rationale for the study.
Right. And important to point out that you included, well over 100 studies with almost 36,000 patients. So this was a pretty broad, pretty big study for this specific topic. And they were randomized controlled trials. So not just association studies, but randomized controlled trials, and, of varying length. But it was that really sort of, I think, elevates it in terms of its place in the literature. And so, I mean, let's jump into it. So what'd you find about the disordered glucose regulation?
Well, so not surprisingly, we expected this. Antipsychotic use was significantly associated with change in all of our primary outcomes. So that included fasting blood glucose, insulin, hemoglobin A1C, as well as our secondary outcome, which looked at the percentage of individuals who converted from normal glucose metabolism to either prediabetes or type 2 diabetes. And then we also did subgroup analyses, which kind of was interested in this weight gain independent effect of these drugs. And what we found is that regardless of the antipsychotic type, which we looked at based on known weight gain hierarchies, or treatment duration, so short-term or long-term studies, that did not impact dysglycemia risk, which suggested that these effects can occur early on and regardless of the weight gain liability of the antipsychotic agent. We also found that this effect occurred regardless of the mental health diagnosis, so it had the same negative effect across all the severe mental illnesses, so schizophrenia, bipolar disorder, major depressive disorder, as well as healthy controls. It was independent of age, previous antipsychotic exposure, or use of other psychotropic medications like mood stabilizers and antidepressants.
Yeah, so many important take homes from all that. And first is actually great for just sort of resetting our mindset that we call these medications antipsychotics, but they're not just used in schizophrenia. They're used as like mood stabilizers in bipolar disorder. They're used as add-on treatment for treatment-resistant depression. So they're kind of used across the board, which I think is really important just to sort of kind of set that expectation of what we're talking about. But the weight gain independent effect, sort of the dose and duration independent effect. Like those were all, I think, really important take homes, because you can always think, well, as long as you're not gaining weight, you're probably not going to have a problem. Or if you're on the lowest dose for a short period of time, you're probably not going to have a problem. Like it could totally make sense that someone would think that about the medications, but your study seems to say, well, no, actually, you could have metabolic issues despite that, which makes it that much more important to say we should be testing metabolic health. We can't just go by weight gain. So, I mean, would you say that's sort of the big clinical take home from this?
Yep. Yeah, absolutely. And I should add that, so there's probably, and we found this also like when we did our like correlations. So there's this weight gain independent effect, right? But when you correlate weight gain and you look at glucose dysregulation, there's probably an additional effect. So it's a double whammy, right? So you have these direct, probably acute effects that, are important because, like you pointed out, that informs clinical monitoring, right? And then you have these over the long term weight gain effects, which add to the complexity and add to the burden. And then, of course, add stigma, lower self-esteem. And then I think Sharmili will talk to that when she talks to the second paper that we're going to talk to. But yeah, so I think it informs metabolic monitoring exactly the way you said it. And that's reflected in our guidelines. For example, the Integrate guidelines on schizophrenia, we published, these are international guidelines, published in Lancet Psychiatry as well. And it also, I think, and like you said, monitor individuals early on more frequently, regardless of whether they're gaining weight or not, for parameters of glucose metabolism and also lipid metabolism. And then, of course, it has implications for practice and interventions as well.
Yeah, and I would argue, just like I do across metabolic health in general, it's not just fasting glucose, which is probably what most people are going to monitor, but they should be getting fasting insulin, HOMA-IR, hemoglobin A1C, maybe even CGMs. Like the more monitoring you can do along those lines, the sooner you're going to catch a problem and then be able to address it. And so you could argue anybody starting one of these medications, or even anybody with one of these primary diagnoses, should be having that type of tracking. But I'd say it's probably the minority right now, but you have hope that that might change.
Yeah, of course. And there's also like issues of scope of practice, right? Like who monitors, who treats. And I think what we're coming to is that as psychiatrists, we should feel more comfortable screening and managing these side effects. As a case in point, with like my one of my primary focuses is schizophrenia, where with antipsychotic treatments, we feel very comfortable managing extrapyramidal side effects, which arguably is much more complex medications than some of the metabolic agents we can speak about and metabolic interventions that we have at our disposal. And I think this is coming out in guidelines as well, where, the prescriber and the psychiatrist should be the central coordinating figure to catch these side effects and then intervene and then loop in specialists as needed because obviously, we can't specialize in everything and do everything, but it speaks to collaborative care and interdisciplinary care.
Yeah, that is so important, because it's so easy to say, not my job, not my department, and hope somebody else is going to address it. But that frequently means it falls through the cracks and nobody addresses it. So important to be proactive about it as the prescriber. So I hope more people hear that, because that's really important. But Sharmili, let's bring you in here, because you're one of the papers that you wrote, Clinical Management of Major Depressive Disorder with Comorbid Obesity, speaks a lot to some of the similar topics, but now we're talking about depression, not talking about schizophrenia, and talking about sort of the combination of obesity, which frequently goes with metabolic dysfunction, and depression, more as like a holistic approach. And of course, Maggie, you were involved in this paper as well. But Sharmili, tell us about sort of the background of this paper. What led you to write this, and then we can get into some of the key findings.
Yeah, and I mean, it really connects to what Maggie has just said. So, I mean, what we really want to highlight is that our conclusion is not to disregard antipsychotic or antidepressant medications. So that's not the conclusion. These medications are life-saving and really needed. But what we really call for is more metabolic control, metabolic management. And it should be, and we really want to equip the psychiatrists with this training. So they should feel comfortable in like screening for this and treating metabolic dysregulation, because as Maggie just said, our patients are dying of cardiovascular events, right? So this is a real risk and a real problem that we face in psychiatry. And so that's why we think that psychiatrists should be really equipped to be able to monitor this and directly treat these conditions. And as Maggie has correctly said, that we have like during the review, we have talked to patients, people with lived experiences, and what they have come up with repeatedly was the double stigma. So psychiatric diseases mean a stigma, and then being obese and having a psychiatric disease is even more stigmatizing. And what they always say is, if I go to endocrinologist, internal medicine person, they will say, it's your depression that is the problem. So if we treat the depression, everything else will be better. And if you go to the psychiatrist, they won't care about your obesity and about all the problems that you face with that. So that's why I think patients really need an advocate for them, but also a person who feels responsible for taking care of both. Because so on the one hand, we know that antidepressants, antipsychotics, and the depression itself increases the obesity risk dramatically. But on the other hand, we also know that obesity also reduces treatment response to antidepressants. So people who are obese respond less to classical antidepressants, but also to like enhanced therapies just like ECT. Also here, the treatment response is reduced if you are obese. So it's really in our interest to improve the metabolic health, to also improve mental health.
Why do you think that is? Why do you think the treatment response is less?
Because so we are more and more learning about this, right? But what we found out is also that insulin resistance really reduces treatment response. And we think that it has to do with, you have like a disrupted brain energy metabolism. So we have like increased energy in the body. There's increased glucose level, but on the other hand, if you look into like brain energy metabolism, you can see, for example, a dysfunction in mitochondria, more oxidative stress. So here there are like more structural changes that happen in the brain, in the periphery, that could really interact with the treatment. Writing this review, we really saw this clinical need and thought, okay, let's give something that you can directly apply. And that's why we really recommended to screen for weight gain early on. And to screen for obesity, to have like a metabolic profile that should be screened by the psychiatrists themselves. So looking into lipid profile, looking in insulin glucose regulation, to look into blood pressure, and also how treatment responsive is this patient. Do we have to like escalate the treatment? We use antipsychotics often for antidepressive treatment as well if we want to escalate the treatment, but could we probably also go on and do rather therapies like ECT, TMS therapy, or also esketamine therapies that has been shown to be weight neutral, but then also look into other possibilities and also include them, just like psychotherapy that is focused on these problems, which could be emotional eating, binge eating. So why are people eating more? Is it just because of the medication, or are there other problems why people are eating more? Look into physical exercise. The effects for physical exercise, I was surprised how big they are, right? And it's hardly used. So, and of course, the fear is that depressed patients won't be able to follow physical exercise. But from studies, we can show that actually depressed patients are able to follow these treatments. And just like doing physical exercise, 30 minutes, 5 times a week, could be highly beneficial, both on metabolic health, but also mental health. And particularly for these body soul exercises like yoga, for example, there is evidence that even shorter durations can be effective. So I think, and if you want your patients to follow a physical exercise, be as concrete as possible. Really prescribe the physical exercise, indicate them toward physiotherapists, and make sure that they really follow the physical exercise. And then other aspects are, of course, dietary interventions. So I think the low-hanging fruit is just advise patients on diet, right? Make them sure that they know, like, soft drinks consumption is not beneficial for your health, which is the most obvious thing, right? And then if that works out, then give them like more dietary recommendation. Then we could also do dietary intervention. We talked about ketogenic diet, and these kind of things, which have been shown to be beneficial in psychiatric conditions. And then, of course, the last step is also to have like metabolic drugs or weight loss medication, like GLP-1 analogs. Consider them early on if you think that weight gain and obesity is really a problem in your patient.
Prevention as well. I think, like, in the field of schizophrenia, at least, we're strongly advocating for prevention strategies as well, at least in the context of antipsychotic treatment, because again, the dysregulation happens so quickly. And, once someone has gained 50 pounds, 100 pounds, they've developed insulin resistance or type 2 diabetes, it's much harder to get an effect. So at least for older medications like metformin, which has been around for 70 years, we now advocate in new guidelines that patients can be offered that, especially if they're at risk for some of these side effects. So metformin co-therapy. And in the field of schizophrenia and antipsychotic medications, there's also now 5 RCTs that have looked at the older glucagon-like peptide 1 receptor agonists. And they show, modest weight loss effects, no mental health adverse concerns, which I think is important. And now there's, I think Sharmili is also pretty excited about this, but there's the newer GLP-1 receptor agonists. So the weekly injectables, semaglutide, and then the dual agonist tirzepatide. And with semaglutide, we've had 2 RCTs published that just came out by our Australian and Denmark colleagues. And they're showing very impressive weight loss, as well as improvements in glucose, lipid parameters, and again, no concerns about adverse mental health effects. So I think, combining the field of dietary interventions, lifestyle interventions, and again, if that doesn't work for some, also considering very early interventions with some of our bigger guns. And arguably, I think ketogenic diets, are a very exciting area where there's a number of clinical trials that hopefully will be published soon, which may have a dual benefit on psychiatric symptoms, as well as metabolic outcomes.
Yeah, I think that last point is so important. If there's a treatment that addresses both the underlying psychiatric symptoms and the metabolic consequences, that's a pretty impressive treatment. And so far, that seems to be what we see from ketogenic therapy. But obviously, as you said, we'll learn a lot more. But definitely something that could be potentially used just as adjunctive therapy to standard of care. And Sharmili, to circle back to what you said about how patients with depression and obesity and metabolic dysfunction have less response to standard treatment, I think that just shows how the one-size-fits-all treatment does not work, right? Everybody doesn't have a serotonin deficiency as the primary cause of their depression, or they have confounding causes as well that also need to be addressed. And I think that that's such an important point for people to realize, that you can't just go by the guidelines of drug A, drug B. If it doesn't work, that's all we got, without addressing the underlying metabolic dysfunction. So I think that was so important. But so let's talk about, there's so much to talk about because we brought up so many different things, but let's talk about exercise for a second, because there is this concept of saying, oh, it's so easy. All you got to do is get out and start moving. And yes, in randomized controlled trials and in studies, people who enroll in studies, it shows it's doable. but we hear from a number of people that like, I just can't get off the couch. I can't motivate to do it. So how do you do in a stepwise fashion to get that person in a place where they're more likely to exercise? Is it addressing the diet first? Is it, optimizing medication doses first? Is it therapy first? Is there like a hierarchy that can make it more apt to be successful?
Yeah, I mean, that's a good question. I mean, and even we as healthy people know how difficult it can be, right, to start doing regular exercise. And I mean, and the good news is so that all these things interact with each other, like sleep, food intake, and exercise highly interact with each other. So if we improve physical activity, even from my studies, we know that food preference changes. So then that high-fat diet, for example, becomes less attractive. So that I think so just starting at some point already makes all of these points easier. And just looking into physical activity, as you said, I think the advice is really to start small. Don't use the escalator, but use the steps, for example. Don't sit all the time, but walk in between. Just go for a walk every day. Go with a friend for a walk. I mean, this could be just a beginning. And when you think, okay, the patient is seeing the effects, then you can do really exercise, which is like structured physical activity. This could come next. Don't start with the most difficult thing first.
Yeah, I love how you said go for a walk with a friend, because I
Yeah.
think bringing in others, accountability partners, support partners, being part of a community and a group, so important by itself. And then to tie that into physical activity, I think is so important. Yeah. And so you both have brought up, ketogenic diets, which I think are really showing a lot of promise. Of course, I'm biased about that. But when you talk about dietary interventions, it seems like, like you said, cut out the soda, cut out the fruit juice, cut out the extra sugar, the ultra processed foods, go towards a Mediterranean diet. That's sort of like standard advice. And I think there's no question if people adhere to that, it is better than the alternative of the standard American diet. But when we talk about changing our brain metabolism, providing ketones for the brain, improving metabolic health, bypassing insulin resistant, blocks that cells aren't creating enough energy because of insulin resistance. When you talk about that, it seems to open up this whole new world. So I'm curious what you both think about the role of ketogenic therapy now as a dietary intervention. Should, the majority of psychiatrists at least be considering it for their patients? Or, some would argue we need more evidence first, but it's a dietary approach, not a drug. So let's hear from both of you. Maggie, you first. Where do you think it stands in terms of recommendation hierarchy for patients and their dietary approach?
Well, I think it's a very, very exciting field because, first of all, antipsychotic medications and other psychotropic treatments don't work for everyone, right? And a lot of them carry this metabolic burden that we've heard about. And often patients get frustrated and they often just want to come off of these treatments, and they do go off of them and relapse. So we need something else, I think. There's probably, no harm in patients trying the ketogenic diet if they're interested in it. And certainly I recommend that to some of my clients who, for example, don't respond to metformin or GLP-1 receptor agonists. But there's challenges. There's challenges with food costs, right? And food security for some of our people who are socially disadvantaged because, healthy food is more expensive and often, the carb-based diets are a lot cheaper than the healthy protein, healthy fat-based diets. So I'm very much looking forward to the trials that will be coming out that look at mental health symptoms and metabolic outcomes. And if we see promising effects, maybe that will somehow promote integration of some of these approaches into care and support into some of these approaches into care.
Yeah, it's a good perspective. I have to point out, I did a very fascinating interview with Moira Newis, at least I was fascinated by it, about a case study of someone she worked with who actually was in and out of homelessness and in and out of shelters and was able to maintain basically a ground beef based ketogenic diet and used it as treatment for his schizophrenia symptoms. So it shows it certainly can be done. in low socioeconomic circumstances, of course, can be more challenging than just going to 7-Eleven and buying potato chips and bread and whatever, but certainly doable.
Yeah, and that's sort of a field that we need to develop as well is, approaches for these types of dietary interventions that can be feasible and, letting us think a bit creatively on how to implement these in people who are disadvantaged, right?
Yeah. So Sharmili, let me ask you then a little bit more about GLP-1s and ketogenic diets and how you see them being different, being the same, synergistic, how to use them together or differently. Like what's your opinion on those two?
Yeah. I mean, there was one important point that Maggie just pointed out. It's fuel for the neurons, right? And we know that obesity and insulin resistance can lead to reduced fuel for the neurons. So that's why I think ketogenic diet is super interesting, so that we have a different fuel for the neurons, which are lacking fuel. But we know that particularly for people with insulin resistance, it can be really hard to get into a ketogenic state. So here, probably also in the beginning, GLP-1 analogs could be helpful. So to reduce binge eating, to get into a more insulin sensitive state, and then adding on ketogenic diet, which could be continued later on, because of course we know from GLP-1 analogs, they work as long as you take them. But as long as you as soon as you stop them, you will regain weight, almost all of the weight that you have lost. So we need a strategy for the time after the GLP-1 analog. So persist on these effects. So that's why I think particularly this combined therapy is highly attractive, particularly for our patient groups.
Yeah. Now, I really like the way you said that, because I think we don't think about that enough, planning for the future, especially when a third or less of patients remain on the GLP-1s after a year. So we really do have to plan for that. Fellow mental health clinicians and healthcare providers, you now have access to a suite of free CME lectures on metabolic psychiatry and metabolic health. Each of these CME sessions provide insight on incorporating metabolic therapies for mental illnesses into your practice. These CME sessions are approved for AMA Category 1 credits, CNE nursing credit hours, and continuing education credit for psychologists. And they're completely free of charge on mycme.com. Now back to the video. Let me ask you the practical question. Can a psychiatrist manage all this?
I'm sure we can. I mean, we are managing the most complicated organ from my point of view, which is brain and like behavior and psychosis and all of these exciting things, right? And from this point of view, we should be able to manage metabolic health. There are like clear guidelines. Everybody learns it during medical school. I think we have to reactivate it and we have to make it a focus. We have to get it into the training of all psychiatrists. We have to raise awareness. And that's why it's really nice that these papers that we have just published were published in these high impact journals. So I hope that really increases awareness for these topics. And also to show that it's not only about metabolic health, but metabolic and mental health highly interact with each other. And cardiovascular risk is a real risk for all of our patients.
And what do you think, Maggie? I mean, when you look at the practicing psychiatrists out there who are not doing this right now, what do you think the hurdle is to get them to adopt this and start practicing it?
I think a lot is comfort level. And that comes back to what Sharmili said, that we have to integrate this into training, just like we teach psychiatry residents to manage extrapyramidal side effects. We should do the same for the leading cause of mortality, which are the cardiometabolic risk factors. And yes, and time is another, I think, factor, right? When you see a patient who presents from a mental health perspective and you have 30 minutes to see them, then metabolism may not be on your list of priorities. But having said that, bringing someone back or having an attached metabolic psychiatry clinic, which is, for example, what we have in Toronto, where people can be referred, and again these collaborations. And also, I think teaching family physicians who may also not feel comfortable managing metabolic comorbidity in someone who presents with, mental health complexities. So it does come back to education and training, and also, disseminating results and studies and guidelines. And so I think it's doable. And I think the field is moving in that direction, which is quite exciting.
And going on podcasts and sharing to the world about your studies. So thank you both for doing that. So I think it is so important that you're out there talking about it, because we need more people to hear about it, and we need patients to hear about it to then bring it to their doctors too, right? There's two ways to learn. There's the top down from the guidelines and the education for clinicians. And then there's the bottom up, educating from patients, which we got to be honest, we hear a lot about with ketogenic therapy, with metabolic health, people for asking for that. So I think that's another way physicians can learn. But again, I really appreciate all the work you're doing, getting these studies published, getting these papers published, and then joining me today to talk about it. So if people want to learn more about you, about your research, about your institutions, where can they go? So Maggie, let's start with you. Where can people find more about you?
Well, I'm embarrassed to say, but I'm not on social media, but you can find me at the Center for Addiction Mental Health website, including my email address, and also at the University of Toronto Department of Psychiatry website.
I think there's something to be said that someone who specializes in mental health is not on social media. I think there's a connection there. It's probably better for your mental health than not be. But how about you, Sharmili?
It's almost the same for me. So please have a look at the website of the Goethe University Frankfurt. There you'll find my email address, and don't hesitate to reach out.
Wonderful. Wonderful. Well, thank you so much. And hopefully we'll circle back again in the future to hear more from you.
Thank you so much.
Thank you, Bret.
Thank you for watching. If you want to see more, check out these recommended videos. Also, if you haven't already, don't forget to subscribe to our channel to stay up to date with our content and help us expand the movement. And if you want to sign up for our newsletter, access our resources, read the latest research, or check out the Think Smart framework, click here to visit our website. See you on the next video.